Good afternoon, everyone. It's my pleasure to welcome you to our webinar, Let's PrEP Talk, a discussion about HIV prevention. My name is Ella Rocker, and I'm pleased to be welcoming Heidi Pharand-Joven, who will be discussing HIV prevention medications, PrEP prescribing, PrEP access, and PrEP barriers in Manitoba. This webinar is taking place on August 17th, 2023. We are recording the webinar today so that we can share it with people who are not able to attend. This webinar is organized by the Manitoba HIV-STBBI Collective Impact Network. This is a network of innovators working collaboratively to transform the landscape of HIV and STBBIs in Manitoba. We bring people together to tackle complex HIV and STBBI systems barriers, and we seek systems change by shifting the conditions that are holding the problems in place. I'm speaking to you today from Treaty 1, Winnipeg, Manitoba. We acknowledge that we work and gather on the original lands of the Anishinaabe, Ojibwe, Cree, Oji-Cree, Dakota, Lakota, Inuit, and Dene peoples, and on the homeland of the Métis Nation. We are humbly working together toward the Truth and Reconciliation Commission's calls for action and the Missing and Murdered Indigenous Women and Girls Inquiry's calls for justice through our research, events, and projects of the Manitoba HIV-STBBI Collective Impact Network. If you would like to find out more about the Collective Impact Network, sign up to receive our newsletter, or find our social media and YouTube page, you can do all of that by visiting us at cinetwork.ca. This webinar is part of our ongoing efforts to provide HIV prevention education. You can find past resources on our YouTube page, and in the fall of 2023, we'll be offering a 5-week intensive training in partnership with Katie. Details will be shared across all our online platforms in the coming weeks. We do have a large number of people registered today, so I ask that you keep your microphone muted. We will have a question and answer period after Heidi Pharand-Joven speaks today, and I ask that you type your questions into the chat. It's my pleasure to introduce Heidi Pharand-Joven. Heidi has been nursing since 2007, and in 2018 became a nurse practitioner. Heidi's early career was focused in ER and ICU, where she started nursing in Montreal. Heidi then moved to Ottawa in 2009. From there, Heidi began working for a nursing agency and traveling to Northern Manitoba Indigenous communities during her off time in ICU. Northern nursing quickly became a passion for Heidi, which is where she developed the temptation to further her education and obtained her master's in nursing, nurse practitioner. Heidi is extremely dedicated and passionate about providing quality, compassionate, and culturally sensitive care to Indigenous communities and marginalized populations in urban areas. Heidi's interest in harm reduction grew out of her many experiences, and in 2020, Heidi gained OAT prescribing privileges while practicing as an NP at Stony Mountain Institution. This combined experience exposed Heidi to a population with increasing rates of HIV and Hep C, secondary to drug use, and men who have sex with men relationships. In 2022, Heidi began working as a contract MP with Purpose Med, where she has been prescribing PrEP in Manitoba and Alberta and has been advocating for increased accessibility, testing, and resources for HIV prevention throughout the province of Manitoba. So it's my pleasure to welcome Heidi today.
Thank you so much, Ella. And thank you everyone for joining on this beautiful Thursday afternoon. I'm going to share my screen with you all here. So this presentation will be rather informal, and I'm definitely open to lots of questions and discussion at the end. So as Ella mentioned, please feel free to enter your questions in the chat, and hopefully we'll be able to answer as many of them as possible. We have quite a large audience with a variety of backgrounds. So we have people from nursing, medicine, community folks, as well as some individuals who have lived experience with HIV and or PrEP. And so the presentation has been made to be in a more kind of simple format with terminology that will be understood by everyone. So let's PrEP talk. What we'll go over today is a brief review of HIV transmission without getting into in-depth physiology of HIV transmission. We'll review some Canadian and some Manitoba HIV data. We will review what PrEP is and its eligibility in the province, as well as some PrEP prescribing guidelines, and PrEP prescribing eligibility processes for physicians and nurse practitioners who are interested in prescribing PrEP in Manitoba. So briefly, HIV transmission, currently in Canada, and now these numbers are, presumed to have increased in the last 3 years. This is from 2020. At that time, there was 63,000 people living with HIV. In Manitoba, there's over 1,700 people living with HIV. A brief kind of discussion here about HIV transmission. Just to demystify some things, there's often some confusion about how HIV can be shared. So essentially, there's 3 factors for HIV transmission. There's fluid, there's route, and there's activity. So transmission through fluid occurs through 5 bodily fluids. And these are bloods. I'm just gonna, whoops, pardon me here. Sorry, one second. There we go. These are blood, semen, including pre-cum, rectal fluid, vaginal fluid, and breast milk. HIV is not transmitted through saliva, tears, sweat, urine, or feces. Of course, unless the feces has blood in it. And so oftentimes people will ask questions about kissing, things like that. And so really important to provide them with accurate information on fluids that are at risk of transmitting HIV. The route, so first and foremost through mucous membranes, and then secondly, when there's a break in the skin that creates access to the bloodstream. And in terms of activity, in Canada, the most common activities that lead to HIV exposure through fluid and route are through unprotected anal or vaginal sex, and sharing injection drug use equipment, so needles, cookers, etc. HIV can also be transmitted to an infant during pregnancy, birth, and breastfeeding. So a review of level of risk per act. So when we talk about sex, so anal intercourse, so receptive anal sex is at the highest level of risk of transmission or acquisition of HIV. Then needle sharing is the second highest. Moderate risk would be anal insertive. So that is risk to the client who is doing the penetration, not receiving the penetration, as well as vaginal receptive, vaginal insertive are moderate risk, and low risk activities for acquiring HIV are oral sex, both giving and receiving, sharing sex toys, and oral anal contact. So some data here, so Canadian data review. This is from 2021 surveillance. If we look here, we can see that there were 1,472 new cases diagnosed in Canada in 2021. That's an 11.3 increase from the previous year. Many people believe that the pandemic had a lot to do with that. And numbers since that time are not quite available yet. And so we can presume, however, that they are even higher. So if you look at Manitoba there, we're at a 10.5 per 100,000 people increase, or percent. So if you're looking at the other provinces, we are the second highest, next to Saskatchewan, who still today maintain the highest HIV rates in the country, and we are at second place, unfortunately, for that. Rates of new HIV diagnoses by sex. So national levels, national rates are 3.8, and males still are at higher rates of acquiring HIV compared to females. But that information is a little bit different when we look at the Manitoba statistics. So another diagram or different view here. This one represents the different categories. So men who have sex with men are the dark blue category or color here at 50.3% of the cases of individuals living with HIV in Canada. Sex between men who also use injection drugs are the light blue at 2.8%. Injection drug use alone is at 13.3%. And interestingly, heterosexual sex partners are at 32.8% nationally. So new HIV infections. Again, here between 2020 and 2021. And this one divides it by provinces. So if you look at Manitoba, one of our biggest percentages here, or the biggest, is injection drug use at 60%, followed by heterosexual sexual partners at 28.2%. Men who have sex with men are at 9.4%. So continuing on that, it was estimated that in 2020, there were 85 new HIV infections in Manitoba. And looking at our statistics, we can clearly see that injection drug use is the leading cause of HIV infections in our province. Secondly, heterosexual people at 28.2% are the second leading cause of HIV infections in the province. And this is actually quite concerning because dynamics are changing provincially, where nearly half of the new infections that are occurring are in females. Another little diagram here just about different geographic locations provincially. So Winnipeg, with the greatest population, obviously has the biggest numbers. However, if you look in the Northern Health region, they had the largest jump or spike in HIV infections in 2021 at 12.4% compared to the previous years. When we talk about populations affected by HIV, so our Indigenous population is year after year the population with the highest HIV infection rates. So in 2017, females accounted for less than a third of HIV infections. And as I previously mentioned, females now account for almost half of the new HIV infections. In 2021, there were 12.2 HIV diagnoses per 100,000 people in Manitoba, compared to the national average of 4.0 HIV diagnoses per 100,000 people. And alarmingly, from January 1st to June 30th, 2022, there were a total of 108 new cases in those 6 months, with 55 being female cases and 52 being male cases. So I just thought it would be important to provide a little bit of data about our HIV rates, as well as the means of transmission, because there's significant problems occurring in our province, as many of you are aware. And so let's dive into PrEP. So PrEP is a highly effective HIV prevention medication. It's a combination of 2 antiviral medications. When used as prescribed, which is daily, PrEP is 99% effective at preventing HIV. Without getting into too much pharmacokinetics of the medications in PrEP, essentially, it interferes with the pathways that HIV uses to cause permanent infection in the body. PrEP can be taken daily or on demand, and we'll talk about that a little later on. And PrEP in Manitoba must be prescribed by an eligible prescriber, and we'll speak on that, about how you can become a prescriber for PrEP. It's very easy. Let's just clarify PrEP versus PEP. I have a lot of clients who have come to me saying that they approached their physician and asking for PrEP, and then their physician started talking to them about PEP, and asking them if they were exposed to HIV, or that they didn't need PEP because they didn't have HIV. And so there's a lot of misinformation out there, hence why I'm very excited to be presenting here in front of you today about PrEP. So PrEP is a medication that is taken before and after a potential exposure, so pre-exposure, whereas PEP, post-exposure treatment, is taken as soon as possible, ideally within 72 hours after a potential exposure. So be it a workplace injury, a sexual exposure, etc. It's initiated within 72 hours after that contact. PrEP is taken on a daily, ongoing basis, whereas PEP is taken every day for 28 days. PrEP is a combination of 2 HIV medications, and PEP is a combination of 3 HIV medications. PrEP is intended for regular use as ongoing HIV prevention, whereas PEP is intended for single exposure use. So currently in Canada, there are 2 options available for PrEP. The first option is Truvada, or generic formulation of tenofovir disoproxil fumarate with emtricitabine, known as F/TDF. This medication was the first PrEP approved in Canada in 2016. It can be used in vaginal and anal tissues, so both female and male clients. And this is the only PrEP option that can be used on demand, as well as daily. The second and newer option of PrEP in Canada is Descovy, which is a brand name formulation. There's unfortunately no generic option for this. This is a combination of tenofovir alafenamide and emtricitabine. Try to say those really quickly. This medication was approved by Health Canada in 2020. Unfortunately, it has not been studied in vaginal tissues and so has only been approved for male or trans female clients. And the use of Descovy is daily only. It has not been studied in on-demand use. A newer option that hasn't arrived in Canada yet, but we are hopeful that it will be arriving soon, is a long-acting injectable PrEP. This is long-acting cabotegravir. It has been approved in the US and is being used as we speak. Studies have shown that it's highly effective at reducing HIV acquisition. One global study among gay, bisexual, MSM, and trans female who have sex with men showed significant results. And the study found that rates of HIV infection were 66% lower in the injectable PrEP group compared to the oral PrEP group. The reasoning for this, as you can all imagine, is adherence. An injection is much easier for many than to commit to a tablet every day. Another study occurring is for cisgender women, which is also showing promising data with reduced rates in the injectable participants. So stay tuned for this. Hopefully it will be coming sooner than later because the data is really promising. PrEP on demand, so this is often referred to as PROD or 211. It's also off-label. So when we talk about pharmacare a little later on, PrEP on demand actually is not approved by pharmacare, but we'll talk about ways around that. There is strong evidence for PrEP on demand, although there is conflicting beliefs within the medical community about on-demand use. PrEP on demand provides 86% protection compared to 99% efficacy in the daily use method. So still better than nothing. It hasn't been studied in groups other than men who have sex with men or trans females who have sex with men. So not appropriate for females or trans males. Truvada is the only PrEP approved, as I previously mentioned, for on-demand use. And on-demand use is not recommended in clients with chronic hepatitis B infections due to the risk of exacerbating disease flares caused by exposure and withdrawal to the medication. So there isn't a ton of evidence to support that. However, amongst many infectious disease and hepatologists, the preference is to avoid on-demand use, to avoid flares and or resistance to similar medications that are used for HBV treatment. On-demand dosing is quite easy. It's 2 tablets 2 to 24 hours prior to a sexual encounter, followed by 1 tablet 24 hours after the initial dose, and then 1 more tablet 48 hours after the previous dose. So in 72 hours, your client would be taking 4 tablets. The one thing to counsel clients on with this is that should the client continue to have sex, they should continue to take 1 tablet daily until 2 days post their last sexual encounter. PROD suitability should be determined on a case-by-case basis, and we'll touch on that shortly as well. So PrEP access in Manitoba. Despite increasing HIV rates, there is no provincial coverage for free PrEP in Manitoba compared to many of our other provinces in the country. Saskatchewan, Alberta, BC all offer free PrEP to their people. Financial support provincially is quite limited. So PrEP is covered under EIA or NIHB, and it is on the formulary for pharmacare. However, pharmacare, a little bit of a pet peeve of mine, and without getting things too political, pharmacare is not the most helpful program for folks who make a wage over a certain amount, because it's all deductible based. And so for people having to meet their deductible, if it's $2,000 a year, let's say, before pharmacare kicks in to provide them with financial support, that's still a lot of money for some people. So it's a challenge. Third-party insurance coverage is quite great for PrEP. Most insurance companies will cover Truvada or generic PrEP, and more now are covering Descovy. I do have a lot of clients who self-pay, and that is a struggle, because they often will have conversations about them, weighing risk versus benefit and budgeting to pay for PrEP, and then cutting back on something else that is a necessity in their lives. So there is a significant financial burden associated with barriers and access to PrEP in Manitoba. PrEP eligibility, and this is the same throughout every province, and as well as with Manitoba Pharmacare. This is their eligibility requirements for PrEP. So individuals at baseline have to be HIV negative. That has to be established prior to prescribing PrEP. And then eligibility for men who have sex with men, or trans women and gender diverse people who also have condomless anal sex within the last 6 months, and any of the following. So infectious syphilis or bacterial STIs in the past 12 months. Individuals who have had non-occupational HIV post-exposure prophylaxis more than once in any of their history. Ongoing sexual relationships with HIV positive partners who have a substantial risk of transmissible HIV. So that means a viral load of greater than 40 copies per milliliter. Or if their HIV status is unknown, but from a higher risk population. So MSM or persons who inject drugs. For men who have sex with men, we utilize a HERE scoring tool, which I'll show you shortly. And the score has to be greater than 11. Gender diverse people are included in this eligibility category because incorrect assumptions can be made about sexual practices, or sexual practices aren't always necessarily truthfully disclosed. PrEP is not recommended for those in monogamous relationships with a single partner and no or negligible risk of HIV transmission. The second category for PrEP eligibility is the heterosexual people. So this is recommended for HIV negative persons with ongoing exposure to HIV positive partners involving condomless vaginal or anal sex. And you would consider PrEP for the HIV negative person in similar situations where the HIV positive partner has a lower but negligible risk. So a detectable viral load, or a viral load that's usually undetectable, but they have other STIs present at time of exposure. Or of course, if their HIV status is unknown. Thirdly, people who inject drugs. PrEP may be considered when there is anticipation or known sharing of injection drug paraphernalia with a person with a non-negligible risk of HIV or if their status is unknown. So for pharmacare eligibility, their HERE score has to be greater than 11. And I'll explain what that means and how we calculate that score. So this is the HERE tool. It is a validated tool. It's used in the Canadian practice guidelines for PrEP prescribing. That said, it does vary in other provinces. Some of the questions are a little bit different. So you do want to ensure that you're using the appropriate tool for Manitoba. Our tool consists of these questions. And so depending on answers, you would score the questions, and the higher the score, the higher the risk of potential HIV acquisition. Now I'm just going to go back to this tool for a second. And so a tool, it is just that. This tool, again, the answers and the scoring is only as good as what is disclosed to you. Pharmacare will approve people based on a HERE score of greater than 11. However, in your prescription, you're not writing the HERE score number. So in that regard, it's really quite irrelevant. For people who present to you with, requesting PrEP with any type of identified risk, or even if they screen very, very low risk, but they're seeking PrEP, one, they've either been talking to someone who is on PrEP, or they feel themselves that they are performing in ways or practicing in ways that makes them at risk of potentially acquiring HIV. So that being said, this tool is there to guide us. I've had clients who have virtually screened zero, but have requested PrEP, are in a relationship with a male partner. The client was male, and admitted to very seldom condomless sex, but still was concerned, about HIV transmission. And so it's really about having that conversation with your client. And I'm someone who is a very firm believer in health, promotion and illness prevention. And so I've rarely denied anyone the opportunity to go on PrEP, as long as they met the requirements, which we will talk about next here. So your pre-PrEP assessment. So you're meeting with a client who has come to you to ask for PrEP. And these are the most important things that information that you'll gather prior to prescribing. So you want to gather a thorough medical history, including prescribed and over-the-counter medications. This is really very important. You want to confirm the client's gender assigned at birth, because this will affect your choice of PrEP that you will prescribe to them. If they have any allergies, you want to screen for signs and symptoms of seroconversion. So any new onset of fatigue, fever, sore throat, swollen lymph nodes, things like that. You want to review the client's estimated and calculated HIV risk using the HERE tool. So again, this is where you are asking the questions in the HERE tool, you're scoring it, but you're having a conversation with your clients and determining, whether you feel, despite the score, if prescribing them PrEP is appropriate for them. Next, you'll be doing some laboratory investigation, which obtaining the results is necessary prior to initiating the prescription. What you're looking for is their baseline renal function, so a creatinine and EGFR. You're also doing STBBI testing, so HIV, syphilis, hepatitis A, B, C, and obtaining a urine for gonorrhea and chlamydia. Now, if you're in an office setting, my PrEP work that I do is virtual. So I'm not able to do swabs on clients. And they can't have the swabs done unless they go to a facility where someone can do the swabs for them. Even if I order the swabs on a requisition and they take that to the lab, the lab techs won't do the oral or anal swabs on them. So this is a provincial challenge, absolutely. But we can touch on that later on. In your female or trans male clients, you want to ensure that you're getting a beta HCG. Because PrEP can be prescribed also in pregnant females and or breastfeeding females. With this, the risk versus benefit should be reviewed. Ongoing monitoring is required for all of your clients on PrEP. So that means every 3 months prior to your refill prescriptions, you're repeating their renal function, as well as their HIV, syphilis, gonorrhea, and chlamydia. And again, in your female, trans male clients, you're repeating that beta HCG. For clients who have an elevated HERE score, so a HERE score greater than 25, which makes them really high risk for HIV, as well as clients with comorbidities, so diabetes, hypertension, previous, renal disease of any kind, and or age of greater than 55, you're repeating their blood work after 1 month of starting them on PrEP. And then from there, every 3 months. So some PrEP precautions that are really important to be aware of and to discuss with your clients. So Truvada or generic PrEP is renally absorbed, metabolized, excreted, so it can affect renal function, and it can also affect bone density. Descovy has much less of an impact on kidney function and bone density, and so it can be used as an alternate in clients who are higher risk for this, or clients who have benefits that may cover Descovy. Oftentimes they elect to go with Descovy when they hear of these risks. With that said, bone mineral density screening or testing is not routinely recommended due to PrEP use unless otherwise indicated. We do recommend that clients avoid nephrotoxin drugs such as NSAIDs, so Advil, ibuprofen, Motrin, naproxen, any type of anti-inflammatory drug, as it adds extra strain to the kidneys, as well as avoid volume depletion and have comorbidities well managed. So ensuring that they are followed by a provider for their diabetes, hypertension, etc. One thing that I've seen in my clients in both Manitoba and Alberta, there's no like literature or anything to support this. But one thing that I've seen is that most clients are healthy, ranging from 20 to 40 years of age, quite physically active. And a lot of people use creatine or pre-post workout products. I have seen this in combination with Truvada affect their renal function. So the main takeaway here is asking about use of these things in your clients, and certainly and I've actually seen a few people who at baseline had abnormal renal function. We had a conversation, we looked at risk factors, medications, over-the-counter meds, supplements, etc. And oftentimes it was attributed to their creatine use, and they stopped using creatine and their renal function improved. So something really important to be mindful of. For clients who are on Truvada or generic PrEP, I always recommend supplemental calcium or vitamin D, as well as a daily vitamin and regular physical activity, all to maintain their bone health. So adverse effects of PrEP. Generally, PrEP is well tolerated, and any adverse effects that clients may experience are typically transient. So as their body gets used to the drug, the side effects go away. Truvada does have a greater side effect profile than Descovy. So another benefit to clients who do have coverage for Descovy, I always describe it to them as the Cadillac of PrEP options. Very minimal side effects and no impact on your kidneys or bone density. The most common side effects that people may experience are things like headache, fatigue, nausea, loss of appetite, weight loss, abdominal bloating or distension, and some diarrhea. It sounds horrible. It would be if they did experience all of those things. But again, many people don't experience any. And if they do, they last a few weeks and then they subside. I have had a few clients who have had some, pretty intense diarrhea and or weight loss. And then at that time, we, have a conversation and review options. And, sometimes we do have to do a special authorization for Descovy, depending on how they're tolerating or not tolerating the Truvada. But generally, symptoms can be managed with over-the-counter therapeutics, loperamide, Gravol, Tylenol as needed, etc. So PrEP counseling. So as great as PrEP is, again, 99% effective at preventing HIV, is phenomenal. It is an extra layer of protection in preventing HIV. We still want to ensure that we're having conversations with our clients about utilizing barrier methods, so condoms, that we're performing regular STBBI testing, and that we're encouraging our clients to have conversations with their partners so that their partners do the same, and continue counseling on safe sex practices and harm reduction practices. The more we talk about it, the more we normalize it, the easier these conversations will be and the more comfortable people will be, as well as it will reduce stigma associated with all of this. PrEP must be taken for 7 days in a row to achieve maximum protection in anal tissue. So really important to inform your clients of this, that it takes the full 7 days and onwards to achieve and maintain that 99% protection. For female or trans male clients, it's 21 days in a row to achieve maximum protection in the vaginal tissue. So significantly longer to achieve that protection in that population. Adherence is extremely important. Taking a pill every day is not always easy. It's important to talk to your clients to see if that's something that they're actually able to do, or is PrEP on demand more doable for them. The benefits, as previously mentioned with the long-acting injectable PrEP, is that, it's one shot and they don't have to worry about taking a pill every day, which is why the study saw such greater benefits to the injectable versus the daily use. If clients are to miss a pill, I always counsel them on taking it as soon as they remember, but to never double dose. And if they're within 12 hours or less of their next regular dose, I just advise them to miss the missed dose and proceed with the next dose as they normally would. I do caution my clients, however, that if they miss more than 2 tablets in a row, that they err on the side of caution and kind of count back to the 7 days to ensure that protection again. We don't know exactly how much efficacy they lose per missed tablet. And so just to err on the side of caution, that's my practice. That's what I do. And most clients are extremely receptive and understanding of that. There's no literature, however, to support that, of course. If a client is stopping their PrEP, we do encourage that they take PrEP for 28 days after their last sexual encounter. And with that, we recommend that they repeat their HIV testing 8 weeks after stopping. And follow-up occurs every 3 months. So we're touching in with these clients quite regularly. Follow-up is generally really quick. We're just kind of seeing how they're doing with their PrEP, if they're having any side effects, how their adherence is going, if they've had any missed tablets, and of course, repeating their STI testing. So prescribing in PrEP in Manitoba is quite easy. There's no specific certification programs. Prescribers must be licensed, Manitoba prescribers, as well as knowledgeable about the management of STBBIs and of PrEP, as well as assuming ongoing monitoring and responsibility of care of these clients while they're on PrEP. So eligibility includes NPs and MDs are eligible to prescribe PrEP. All you have to do is fill out this prescriber registration form, which is on the next slide. I'll show you, and we'll also include it at the end of this presentation. We can send it out to you, and the form is to be submitted to the stbbi@gov.mb.ca. It's really quite quick. Once you send in your application, within a week or two, you're added on the registry and you're good to go. So this is the form that you fill out. Again, really, really quick and easy, which is lovely. PrEP education. Obviously, you don't want to be prescribing PrEP without being informed of what you're prescribing and what the PrEP kind of climate is across the country. Some really great resources are PrEP Alberta. They have an online e-module that you can complete free of charge. It's really informative. It doesn't take very long to do it all, but it's great. Katie obviously has a ton of resources about HIV and PrEP information as well. And British Columbia Centre for Excellence in HIV/AIDS has a really great page with resources as well as learning modules. So there's lots of information out there. Even if you Google PrEP Canada or HIV Prevention Canada, you'll get a whole list of different things that are great to browse through. But in terms of required courses for Manitoba, there's nothing specific other than that registration form. So as we conclude here and open it up for questions, the takeaways are that PrEP is a safe and cost-effective means to reducing HIV infections. Primary care clinicians need to speak to their clients about sexual practices, drug use, having those raw conversations with your clients, getting to know them, and identifying, their risk of harm and their risk of acquisition of HIV through different practices. Offering routine STBBI testing to all clients, irregardless of age, who are sexually active. So if you have a 15-year-old or a 12-year-old or an 85-year-old, if they're sexually active, it's really important to offer STBBI testing along with their, their routine blood work or whatnot. Or if they're coming in with specific problems where you think it might be related to an STBBI, obviously offer testing at that time. But again, the more we offer testing and talk about testing, the more awareness we're creating, and we're reducing stigma associated with STI testing. Emphasize harm reduction and normalize harm reduction equals a reduction in stigma. So super important to have those conversations with your clients. And increasing community awareness about HIV rates, sharing that information, sharing methods of infection, preventative measures and safe practices, empowering the community and people to make informed decisions and assist them with safer practices will hopefully help with reducing HIV rates in our province. We need to do better, and we can do better. Thank you very much. Questions?
Thank you so much, Heidi, for your presentation. I'm going to put into the chat for folks that are here with us today our evaluation form, and we welcome your feedback on the presentation today. And we'll hop right into questions because we have a lot of really great questions here in the chat for you, Heidi. So the first question is about what you mentioned about the 21 days that it takes for HIV prevention medications to become effective in vaginal mucous membranes. And the question is about any research that you're aware of that's been done into how hormone replacement therapy may impact HIV prevention medications. This person is asking specifically about PrOD efficacy for trans people.
Yeah, so firstly, PrOD is not an option for clients born female. So in terms of hormone replacement for those clients, they would have to do daily PrEP. And in fact, in terms of drug-drug interactions, there's very minimal interactions between tenofovir and other medications. So that's a huge plus. But yeah, so unfortunately, PrOD would not be an option for those trans male or born female clients. Now, for trans female, that I'm aware of, I'm not aware of any interactions specifically that would affect their hormone replacement.
Thanks, Heidi. We have quite a few questions and a lot of conversation going on in the chat about people who are using drugs and injection drugs specifically. And the questions are around the effectiveness for people whose main risk would be through injection drugs. So we talk about the effectiveness of prevention through sexual practices. And the questions are around how do you support your clients who are using drugs to use PrEP, and are there any differences in effectiveness for people who are using injection drugs and are looking to prevent HIV through PrEP?
So simply, we don't know specifically. There's no studies. All of the studies have been for primarily men who have sex with men groups. There have been some in the men who have sex with men who also inject drugs, and then female studies. Studying clients who inject drugs, there was some research on it, and it just basically said that it was very limited because of adherence and follow-up etc. Now, we do still encourage the use of PrEP in clients who do use, who do inject drugs. In terms of how long it would take for PrEP to achieve its maximum protection, you know, that we don't specifically know, but we know that it prevents HIV. So it's really about having that conversation with your client. If they are injecting drugs, you know, having that conversation about adherence. So, you know, going over that it's important that they take it every day. They wouldn't be able to, prod would not be an option for them. It would have to be daily PrEP use. But we still do encourage it, and it is still part of the guidelines and on the formulary with pharmacare eligibility approval for clients who do inject drugs.
Thanks, Heidi. That's really useful. Some questions around who is able to prescribe. So specifically, someone's asking, are registered nurse authorized prescribers, RNAPs, able to prescribe?
Not that I am aware of. I know the RNAPs are now being able to prescribe like STBBI treatment and birth control and things like that. At this time, I believe, and it may, you know, truthfully, I haven't looked into the RNAP in terms of the from a college perspective. But last that I saw on the application, like registration forms, it was specific to NPs or MDs.
Thanks, Heidi. Another technical question here. At what EGFR will PrEP not be ordered?
So anything less than 60. Now, with that, I have, if they have an EGFR of 58, but their creatinine is normal, I have had people continue on their PrEP with close monitoring. We've looked at other possible causes, dehydration, other medication uses, NSAIDs, infections, and then, you know, we do other labs. So we do like a full urinalysis, a urine albumin creatinine ratio, etc. So the EGFR on its own is not a dictator, but it's really looking at their renal function as a whole. But at baseline, if their EGFR was less than 60, generally I would, you know, and with a abnormal creatinine, Truvada then would not be an option for them. And if they had private insurance, we could try for Descovy, so generic PrEP, brand name PrEP through their insurer, or request special approval.
Thanks, Heidi. One last question here before we finish our webinar. What have you found helpful in supportive measures for adherence of PrEP in people who use substances? Do you have any thoughts or mentorship or words of wisdom that you'd like to share with folks who are looking to support members of their community who are using substances and are potentially at risk?
Oh, that's a tough one. I mean, we all know that that's really hard, right? And people who use substances are often in survival mode. And so PrEP or a medication that doesn't make them feel any better or worse often is something that they don't prioritize. I think for these clients, you know, having regular check-ins with them would be beneficial. Again, just empowering them and encouraging them. Any amount of PrEP that they take is better than no PrEP. certainly long-acting PrEP, injectable PrEP would be, the absolute best for these clients because they don't have to worry about it. So hopefully that comes sooner than later. But again, it's a challenge, just like having them take any of their chronic disease medications if they're diabetic or have any other kind of comorbidities. It's a challenge. And so again, it's really about establishing that therapeutic relationship with them, establishing trust, and empowering them and encouraging them to prioritize certain things. They'll understand, if they're using drugs and they're at risk of HIV from sharing equipment, then PrEP it might save their lives. So having those raw conversations with them, and if you have support services in your facilities, nursing, you know, can check in periodically, once a week, twice a week. There are certain apps that are available if they have a cell phone even, but PrEP reminder apps or things like that can prompt them and help them remember to take their pill. Yeah.
Thanks so
It's
much.
tough.
Yeah, thank you so much, Heidi, for your presentation and your willingness to share your insights on these questions. We really appreciate it. And we're very happy to have had you today. For folks that are on this call, we will be sending out a list of resources to you, as well as some resources that were shared in the chat today. And just thank you all again for your time, and thank you again, Heidi, for your time and expertise.
Thank you very much.